See, tuberculosis of the spine is always secondary to a primary TB elsewhere. It could be a pulmonary tuberculosis or a visceral tuberculosis. It normally occurs 2 to 3 years after a primary tuberculosis. The most common site of skeletal tuberculosis is spine and next followed by hip. It usually affects the immunocompromised patients, mainly those who are on HIV, steroids, those diabetic, malnutrition. Genetic predisposition has also been postulated. Even then, we have seen patients with who are extremely normal having spinal tuberculosis. Tuberculosis of the spine has been documented in ancient mummies from Egypt and Peru, and is one of the oldest demonstrated diseases of humankind. It was Sir Percival Port who described spinal tuberculosis in 1779. Although it is rare in industrialized countries, the significant cause of disease in developing countries. More than 30 million patients suffer from overt tuberculosis in the world today. Among them, 2 to 3% have as I told earlier, the infection in the spine is almost always secondary to an infection in the lungs, lymph node, or in the anywhere in the abdomen, or so for that matter, it can spread through the lymphatic spread, venous spread, or the arterial spread. It can reach the synovium of the bone. From there, the inflammatory response occurs, and as you all know, it will be followed by coagulation, necrosis, and granuloma. All these are pathognomonic of TB. Each of these has got a bearing on the neurological manifestation of tuberculosis of the spine. Tuberculosis of the spine is classically described in 5 areas. Basically, first type is the paradiscal, adjacent to the end plates. In the central type, it's the central part of the vertebra. The anterior part is the anterior type, the posterior type, and synovial. The paradiscal type is the commonest type. 98% of the cases paradiscal. It's most commonly seen in adolescents. Infection spreads through the end arteries. Frequently, it is seen to involve in the adjacent part of the vertebra. Vertebra develop from sclerotomes. Upper part of the lower vertebra and the lower part of the upper vertebra develop from a single sclerotome. So they have a single blood supply. That accounts for why it's paradiscal is the commonest type of tuberculosis. Initially, there is hyperemia, and that will cause distraction of the paradiscal bone, which causes the extrusion of the disc material into the spongy paradiscal area. And later on, what happens is that there will be collapse of the paradiscal bone. The end plate is lost, and the material will go, and the causation material will go in either anterior or posteriorly. That's the paradiscal type. The central type is more common in children. The root is through the Batson's venous plexus. The Batson's venous plexus has a peculiarity that they have got no veins. They are valveless veins. They communicate frequently with the abdominal structures. The vertebrae loses the normal trabecular pattern and softens and compresses. There will be some sort of vertebra plan insert in a collapse. Multiple levels may also be seen. The anterior or the periosteal type is very rare. It occurs in the thoracic region, infection below the anterior longitudinal ligament. It may cause anterior wedging of the compression of the vertebra. See, the thing is that anteriorly we have the aorta and the vascular structure that will cause pulsations, and that will cause sawtoothing appearance of the anterior part of the vertebra. You can appreciate the anterior tuberculosis here. And the posterior appendiceal is very rare. It occurs in the pedicle, transverse process, lamina, or the spinous process. They have a higher incidence of neurological deficit. Lateral shift and scoliosis also has been documented more in the posterior appendiceal type of tuberculosis. Arthritic type occurs in atlanto-axial joint, atlanto-occipital joint, and the facial joints. These are very rare, but things they are associated with spinal instability and neurological deficit. Now we have rare presentation of a spinal tumor syndrome, where the tumor arises on the metaphyseal part of the posterior part of the vertebra and presents as a spinal tumor syndrome, mimicking an intraspinal lesion. Could be a neurofibroma or astroglioma or any intraspinal lesion. Hence, it resembles a spinal tumor syndrome. Here, there will be no cord compression. X-ray will be normal. It essentially resembles that of a spinal tumor. The clinical features in the active disease, as has been already mentioned, malaise, fever, weight loss, appetite, loss of appetite, even rise of temperature, generalized body aches will be present in active phases. Pain may be aggravated by spinal motion, coughing, or weight bearing. The pain is referred usually along the spinal nerves. The cervical region will be referred along the occiput or in the arms. Thoracic, the intercostal nerves are involved, so it could be an intercostal neuralgia. Thoracolumbar, you get the girdle pain or the epigastric pain. The pain may be referred to the hips and the legs. Night cries are a more feature of thoracic and cervical spine. The pain is usually local, stabbing type over the affected vertebra, aggravated by movements and pressure. The signs of active disease, the strained, expectant facial expression will be there. Avoids sudden movement, walks with the semi-flexed hip, avoids all movements of spine on locomotion. If the lesion is in the upper cervical region, he holds the head as if the patient is having a wry neck without rotation of the face. If it's in the lower neck, the patient's head is thrown backwards to one side, head supported with both hands. Upper thoracic region, you get the classical military attitude. The lower thoracic region is the Alderman's gait, wherein the thorax and the head is backwards, and the abdomen is protuberant, and the legs are apart. Lower lumbar region, this increased lumbar lordosis and loss of costo-iliac distance. The signs of active disease will be the paravertebral thickening, tenderness, spasm of the paravertebral muscles. Then the movement of the spine will be grossly reduced. The spastic spine is the protective mechanism of the body to prevent the neural structures from touching the offending structures. It could be a tumor, it could be an infective material, granuloma, or anything for that matter. Patient, when he is asked to pick up a point from the floor, avoids bending the spine. Deformities, if you palpate along the spine, you can actually palpate deformities. If one or two vertebrae is involved, it's called a knuckle vertebra. If 2 or 3 is involved, it's called angular deformity. More than 3, you get the classical rounded kyphosis. Neurological complication is the most dreaded complication and crippling complication of tuberculosis of the spine. It's more common in the first and third decades. It's more affecting the dorsal spine because spinal cord ends up below the level of L1. The canal is narrowest to the thoracic spine. Normal thoracic curve encourages kyphosis, and the anterior longitudinal ligament loosely confines the abscess. For these reasons, the dorsal spine is the common site of paraplegia. Now, coming to the causes of paraplegia, the paraplegia causes could be early onset or late onset. Early onset in the meaning that paraplegia occurring within 2 years of onset of the disease. Late onset means occurring after 2 years of onset of the disease. The cause of early onset paraplegia could be an inflammatory one. As I told you, it could be an edema, it could be tuberculous granuloma, abscess, or the caseous tissue which is pressing on the spinal cord or the neural tissues. The vascular problem is an acute thrombotic event. Again, you have the mechanical event. That's the rapid increasing kyphosis. When this rapid destruction of the vertebra, sequestra, or the debris, all these things can cause rapid compression. These are cause of early onset neurological deficit in tuberculosis. Well, this can also occur in late onset paraplegia. It's after 2 years once the disease has been cured. That's mainly inflammatory cause. It is very, very rare, but mainly vascular. It could be endarteritis, which could be a microthrombi, or it could be infective thrombus. Again, you can have a mechanical obstruction in the form of an internal gibbus. And the heels that can cause stretching of the spinal cord over the heel vertebra, canal stenosis when the canal diameter is decreased, or spinal instability when the architecture is lost, or very rarely spinal tumor syndrome. The cord changes per se, myelomalacia, syringomyelia changes, or meningomyelitis can also contribute to the neurological deficits which occur in tuberculosis spine. Now, what are the clinical signs of paraplegia? Most common things, the patient may not be aware of these signs. Most symptoms, maybe the patient may be having a clumsiness while walking. Spontaneous twitching of the muscles will occur. The clinician usually elicits an extensor plantar reflex. There will be signs of hypertonius, accelerated reflexes, sustained clonus of the angle and patella. Motor are more affected than sensory. Bladder and sphincters are involved in the late stages. Vibration and position sense are the last to go because they are the dorsal column sensations. When the recovery occurs in the reverse manner, vibration and position sense occurs first, followed by temperature, touch, and pain. Voluntary motor activities, finger muscles, and muscle wasting. That's the order of recovery. The cold abscess has been dealt by Dr. Viswanathan extensively, but it's found in almost 20% of the cases. It is found by collection of the products of liquefaction and reactive exudation. It is composed of serum leukocytes, caseous material, bone debris, and tubercle bacilli. It extends from site of origin along the paths of least resistance, guided by facial planes and along the nerves and blood vessels. So abscess penetrates the ligaments and migrates in various directions following the facial planes and comes superficially. It as a sinus or an ulcer. The walls of the abscess or sinus are covered by tuberculous granulation tissue. It is cold because there is no signs of any inflammation. Cervical abscess can track along abscess can go into the epidural space or into the retropharyngeal region, producing a retropharyngeal abscess. It can also track down into the mediastinum, enter the trachea, esophagus, or a pleural cavity. Posteriorly, it can track into the anterior or posterior triangle of the neck as a cold abscess. It can also track along the brachial plexus as swelling in the arm. Dysphagia, respiratory distress, and hoarseness of the voice are the symptoms of involvement of the cervical spine in the retropharyngeal region. Dorsal abscess in the thoracic spine can track into the mediastinal region or track along the intercostal nerves as cold abscess elsewhere. So you can find either a pigeon nest or a pigeon nest appearance in the cervical spine. Then the lumbar spine, what happens is that you can also track into the epidural space or along the psoas muscles, psoas abscess. You can track along the vessels into the gluteal region, thigh, inguinal regions, or in the iliac fossa, or even into the leg as well. So the common clinical manifestations: clinical kyphosis present 95% of the patients, cold abscess in 20%, tuberculous sinus in 13%, extraskeletal fossa in 12%, and skip lesions in 7%. 20% patients patients have neurological symptoms. To differential diagnosis, you have to note only infections and metastatic or tumor conditions. Pyogenic infections of the spine, brucella, typhoid are the infections which can mimic tuberculosis of the spine. Then you have the malignant conditions such as lymphoma and metastatic deposits. These are the things which has to be ruled out in the differential diagnosis. And thanks to the previous speaker, he has essentially told about how to diagnose those things. Then sometimes you may find an isolated ivory vertebra. Ivory vertebra is a differential diagnosis of heel tuberculosis, but it can also be found in lymphoma, osteoblastic metastasis, Page's disease, or a healing tuberculosis. Now, I told you about the collapsed vertebra, but it's a differential diagnosis of osteochondritis and Cal's disease. But here in Cal's disease, the total collapse is only one vertebra. Other one, tuberculosis, you may find more than one vertebra. Here in Cal's disease, the vertebral disc is spared. In tuberculosis, the vertebral disc is almost always involved. There's increased involved density of the lower vertebra in Cal's disease. Other one is osteopenia in tuberculosis. Now, how to diagnose it? It has been alluded by the Murali. Blood investigations, there will be leukocytosis, an elevated ESR and C-reactive protein. X-ray findings, 50% of the bone destruction has to occur for the X-ray findings to manifest. You can find the straightening of the spine, and you can find, if you look carefully, you can find there is an increased density of increased prevertebral shadow, and here you can find the destruction of the vertebral body in cervical spine. The dorsal spine, you can find the fusiform appearance as well as the bird nest appearance. These are the findings of tense abscess in the tuberculosis of the dorsal spine. In the lumbar spine, it's actually the paradiscal area is affected. You can find the destruction of the paradiscal area in the vertebra, and the end plates destruction is well appreciated here. Here again, the abscess can track along the facial planes. Now, anterior and in X-ray, I told you the anterior part, anterior tuberculosis. This is the anterior tuberculosis. Due to aneurysmal effect of the aorta over here, there will be anterior scalloping of ends of the vertebra, and sawtooth appearance of the vertebra can be appreciated. So, as abscess, if there is abscess from the lumbar region L2, 3, 4, you can appreciate the radiological shadows of bilateral psoas abscess in this radiogram. Radiological classification can be divided into pre-destructive, early destructive. Pre-destructive, there is straightening of the muscles. If suppose you find a straightening of the vertebral column in any X-ray, that could be due to a protective spasm. It could be anything. It could be tuberculosis, it could be metastasis, it could be infection, or it could be tumor. So anything, any straightening of the bone has to be viewed with suspicion. MRI or bone scan will reveal bone edema. In the early destructive phase, you find disc space narrowing and end plate destruction. And again, mild angular kyphosis, moderate and severe kyphosis, depending upon the degree of vertebral destruction. So any patient you find a straightening of the vertebra in cervical spine or the lumbar spine, keep in mind that something is touching the cord and the patient is having a protective spine. That could be tuberculosis, it could be any metastatic deposit. So you have to rule out all these things. There's an algorithm for finding such. MRI is the investigation of choice. Dr. Murali has explained why it's modern, because it can show the extensive involvement of soft tissues, the tracking of the cold abscess and destruction of the spine and spinal cord. Everything can be appreciated in MRI. It's the investigation of choice in tuberculosis. It also helps in diagnosing and distinguishing between other metastasis and lymphoma and all the other conditions. CT scans are important. They are useful in TB of the craniovertebral junction, in cervical dorsal and cervicoiliac and sacrum tuberculosis. Bone destruction and spinal cord abscess are best seen in CT scan as well. CT scan is very useful because you need to have tissue diagnosis. CT guided biopsy is also important. CT scan showing cold abscess. Again, destruction of the spine, CT spine. Cold abscess, you can appreciate anteriorly, cold abscess. Then again, dorsal spine. Now, the key to this thing is any patient with back pain, you have to ask for a tissue diagnosis, because after 1 or 2 consultations, patient is having elevated ESR, which may be high or in the medium range, suspicion, spasm, straightening of the cervical spine. You ask for other ancillary investigation. X-ray suggests suspicious. You need a tissue diagnosis. Tissue diagnosis is the mainstay in the diagnosis of pulmonary tuberculosis, because you are not justified in starting ATT without having a tissue diagnosis. The tissue diagnosis is ideally done by a CT guided one, or if it fails, you can go in for an open biopsy. Once the tissue that is obtained, you can send it for dam staining, to AFP staining as well as culture. Culture is very important because you need to know the sensitivity, because nowadays MDR tuberculosis is on the rise. The culture is usually done in solid media as well as liquid media. In solid media, contamination is less, liquid media, contamination is more. Drug susceptibility is all very important in our scenario because it's done in 2 ways, in culture media as well as molecular testing. Molecular testing has been elucidated by Dr. Aladia and other previous speakers. I will not be going to that. But this is the algorithm you are suspecting an infection or a pain back, you have to go for an X-ray and ESR. Suspecting. If it's negative, then you think of other conditions, the tumor, arthritis, or trauma. Then if you're suspecting tuberculosis, you go for an MRI. MRI, again, if it is positive, you go in for a CT-guided biopsy or a needle biopsy. If it is positive, start ATT. If it is negative, again, you go for either isotope scans. And if it's positive for that, again, you go in for a CT-guided closed biopsy. And repeat, if it's again negative, you repeat a closed biopsy. If it fails, go for an open biopsy, then go for the treatment. Tissue diagnosis is imperative in starting ATT in case of skeletal tuberculosis, because it may be a metastasis which you are missing. So you don't want to be in soup. So the goals of treatment in tuberculosis is eradication of tuberculous infection, prevention and treatment of neurological deficits, and prevent and treatment of deformities in tuberculosis. Treatment is categorized in 5 categories: general treatment, local treatment, and treatment of complications and treatment of paraplegia. The general treatment includes improvement of hygiene, healthy surroundings, and liberal nutrition. The specific treatment is chemotherapy, ATT, which is given to HRSD for 2 months and is continued for about 9 to 10 months. I usually give it for 12 months, and the patient is not improving, we will continue for another, maybe another 6 months. We look for the patient's general condition, look for the ESR, X-ray, radiological evidence of healing. If the patient is not improving, you continue ATT for maybe 1.5 years. It was as early as 1965, Girdlestone has stated the effect of ATT. In every skeletal lesion, there are areas of bone sensitive to ATT but are not necrosed. These will recover under treatment. There are also areas of ischemic bone, and these will also recover as disease subsides. Finally, areas of necrosis past recovery harboring TB, for which surgery is essential. Operation should be limited to such foci. Yeah. So that is the treatment. So the treatment will be, local treatment is to immobilize the spine, to allay the spasm, to remove the abscess and dead tissues, to prevent deformities, to arrest the progression of the disease, and to cure disease. The treatment, uncomplicated, is always conservative. There are 3 stages: stage of recruitment, and the patient is asked to stay in bed for the initial 3 months, and then you assess the treatment, and then the patient is improving. The patient is allowed ambulation with the help of braces. In the stage of convalescence, the patient is allowed to wear braces for at least for a period of 2 years. Mind you, ATT is continued till the patient has got symptomatic relief or elevated ESR is coming down, the patient is symptomatically better. Now, what are the indications for surgery? Indication for surgery in patients without neurological deficits will be failure to respond to chemotherapy for a sufficient length of time. Could be you can give a chemotherapy for 6 to 8 months. The patient is not improving. You suspect something is wrong. You're wrong diagnosis probably. You have to go in for diagnosis. Progressive bone destruction in spite of chemotherapy. You must suspect MDR as well. But again, this again warrants a diagnosis. When you are uncertainty in diagnosis, you have to go in for surgery. Evacuation of paravertebral abscesses has been illustrated by Dr. Vishwanathan. Then a recrudescence of the disease, then instability of the spine that needs spinal fixation, and cervical lesions of cervical spine lesions causing paravertebral abscess, causing difficulty in deglutition and respiration, needs drainage through transoral methods. And children severe kyphosis and with extensive dorsal lesion also need surgical intervention. But those patients with neurological deficits, when do you go for surgery? Failure to respond to chemotherapy for 3 to 4 weeks when the patient is having neurological deficits. Development of fresh neurological complications during the course of chemotherapy. For mechanical instability after healing. Advanced case of neurological involvement such as marked sensory loss and sphincter disturbances, flaccid paralysis, and flexor plasm. In all these cases, you need to go in for a surgical intervention. After surgical intervention, the patient has to be in bed. Then again, you watch for the signs of improvement by radiologically and ESR and clinical parameters, and then patient is allowed gradual ambulation with braces, and then braces are worn for a period of 2 years. So what is the essential technique of surgery is actually you have to decompress the spine, followed by radical debridement and arthrodesis. The decompression is mainly done through 2 methods: the dorsal spine through posterior transversectomy and anterolateral decompression. Here, this is the structures which are removed, and you reach the vertebra and remove the affected vertebra. And again, here against anterolateral decompression, this much part of the rib transverse process and the vertebra is removed. And again, after that, what you do is you have to do surgical fusion. Surgical fusion could be due to with instrumentation or without instrumentation. Without instrumentation, you put what as fibular graft or other graft. Here we have instrumental fusion is being done nowadays. Now, spinal tumor syndrome. Here, this is the only condition wherein you do a laminectomy in tuberculosis. Otherwise, there is no role for laminectomy in spinal tumor syndrome. Here, you have to do a laminectomy and the granuloma is removed. That's how you treatment of spinal tumor syndrome. heal disease, you have to do when the patient has got internal gibbous, you have to remove the internal gibbous by anterolateral decompression, and the bony ridge is removed and the cord is transposed anteriorly, followed by spinal fusion. The crux of the presentation, you should have an high index of suspicion when the patient presents back who is not responding to your conservative management for a period of 4 to 6 weeks, then a suspected elevated ESR and a straight cervical spine, suspect tuberculosis or malignancy, go ahead with a diagnosis of MRI, and if the MRI is suspicious, go ahead with the tissue diagnosis. A tissue diagnosis is essential before starting an ATT. Because of the complications of ATT, suppose patient develops some complications, you are likely to be sued. So a tissue diagnosis is imperative in the treatment of skeletal tuberculosis. Thank you very much for your patient here.